Okay, everyone, I am going to attempt to do your Theory Quiz 2 review video. I got a new microphone for my computer, so hopefully it sounds a lot better for you. It is going to encompass a lot of chapters, so you're looking at 29 through 34, which some of the chapters are short, so it's not as bad as it sounds, and there are 100 questions on the test, no bonuses, and nothing to label, no pictures, no diagrams, nothing like that. It's strictly 100 multiple choice questions. So let me get started with the slideshow. Okay, so starting from chapter 29 with some important facts that you need to go over to make sure that you know for your test. When we talk about chapter 29, we are addressing something that you've learned in anatomy and physiology, which is the human cell. Now, you have to remember that the cell is the basic functional unit of all plants and animals. So, very important, the very basic element of humans is the human cell. And we need to go over the main parts of the cell. You do need to know what most of them do. So this is kind of what they look like. And then the next slide I'm going to show you is from my notes. So it's really kind of hard to read. So make sure you listen carefully. But just to show you from the graphic here, the nucleus. So this is where your DNA is going to lie in the nucleus. This peach-colored material all inside the cell is your cytoplasm, and that's mostly what your cell is made of, is the cytoplasm and the nucleus, and it's mostly cytoplasm. The mitochondria are here. These are the powerhouses of your cell. And then you've got your endoplasmic reticulum and your little ribosomes and your lysosomes, which are your garbage collectors here. And let me go to the next slide so that you can see my notes. Now, I know they're not the greatest, but just to reiterate, the two major structures of a cell is the nucleus and the cytoplasm. The nucleus contains the DNA. It does have some RNA, protein, and water, but primarily the nucleus is the DNA. The RNA is primarily in the cytoplasm. The nucleolus is the rounded structure that contains most of the RNA, controls the passage of RNA into the cytoplasm. So if we go back a slide, the nucleolus is kind of internally here, and that's where everything is going to be centralized. Actually, do they have a good picture? No. Oh, well. Here's your nucleoli. So right inside here, one would be a nucleolus, but there's two, so they called it nucleoli. But anyway, that's where your RNA is going to be if it is in the nucleus. Okay. Cytoplasm. It makes up the bulk of the cell and contains everything else except the DNA. So just a reminder, the DNA is only in the nucleus. Then you've got your endoplasmic reticulum, your ER, which is a channel or series of channels that allows the nucleus to communicate with the cytoplasm. And I'll go back again. See, here's your series of channels. That's your endoplasmic reticulum. And then I've already pointed out the mitochondria, which are large bean-shaped structures that digest macromolecules to produce energy. That's the powerhouse of the cell, like I said earlier. The ribosomes were those small little dots that were like near the endoplasmic reticulum, and that's the site of protein synthesis. Now, you need protein synthesis in order for normal cellular function. So let me go back, and here, these little dots, that's your ribosomes here. And your lysosomes, like I said, those are your garbage disposals. Those are those small pea-like structures within the cytoplasm, and I'll go back and just repoint that out for you. So again, here's your lysosome. And then we're going to talk about the membrane, but that's the structure that lines the cell itself. See, membranes. Membranes consist of lipid protein complexes that allow small molecules and water to diffuse from one side to the other. So membranes are just barriers that allow passage. Okay, just like I said earlier, some things to remember. The RNA is primarily located in the cytoplasm. And in order to build larger molecules, those macromolecules, things like that, cells undergo what's called cellular metabolism. And in order to have metabolism, you need two things. You need catabolism, which is the breaking down, and you need anabolism, which is the building up. I like to think of it as catabolism being like a catastrophe, breaking down, and anabolism. I just remember A for adding, so you build it up. I don't know if that helps, but that's how I always remember it. The body is mostly composed of 80% water. Most of our interactions from irradiation are because of the radiolysis of water, because there's so many water molecules to work with. So most of the interactions are indirect, and we'll talk about that a little later. But just to get that started in your head, that water is usually what causes our reactions within our body after irradiation, and it's usually from indirect effects. So the rest of the body composition is 15% protein, 2% lipids, 1% carbohydrates, which that provides the fuel for your cell metabolism. And then you've got your nucleic acids, which is your RNA and your DNA, deoxyribonucleic acid, and this is just ribonucleic acid. And then we've got this 1% of other, which who knows what's floating around in our bodies these days, but they just put it there for good measure. So when we talk about DNA, it is the most radiation sensitive target molecule in the human cell. So when we talk about target theory later on, your DNA is your direct hit. That's your target molecule. So if it hits DNA, it's direct. If it hits water and then hits DNA, then it's an indirect hit. So just kind of keep playing that in your head, because there's going to be quite a few questions about that. Again, the DNA is located in the nucleus of the cell. It is a macromolecule, meaning a large molecule, and it is contained on the chromosomes. So just remember, all our DNA, all our information is contained on the chromosomes. So when we also talk later about chromosome aberrations and mutations, you'll just remember it's all impacting the DNA. Okay, again, kind of difficult to see, but this is cell proliferation from my notes. And proliferation just means multiplying or more, making more of. So human cells proliferate in two different ways because we have two different kinds of cells. So the two different cells that we have is somatic and genetic. Now, the genetic cells are the oogonium in females and the spermatogonium in males. And the process for cell proliferation that they undergo is meiosis. The somatic or body cells undergo a process called mitosis. And we'll talk a little bit about the difference between the two, but mitosis is actually copying the cell, whereas meiosis actually ends up dividing. So let's just go on to the process of mitosis. And again, I know it's hard to read, but these are my notes, and you did ask for them to be put up, so these are provided to you. But the process of mitosis has basically two phases within the cell cycle. The first is mitosis itself, or the M phase, and the second is interphase. So the definition of mitosis is the division phase and has 4 subphases. The 4 subphases are prophase, metaphase, anaphase, and telophase. During prophase, you've got that nucleus that begins to swell, and then you can start to see the DNA. It becomes more prominent. During metaphase, the chromosomes begin to appear, and they are lined up along the equator of the cell. Anaphase is the splitting of each chromosome at the centromere. So that's when it splits apart. And then during telophase, those chromosomes now disappear and your DNA forms. So that's kind of the end result, is the telophase. The interphase portion is that time in between where everything is kind of happening. So it's the portion of the cell cycle between mitotic phases. It's the period of growth of the cell between divisions. There are 4 phases within interphase itself. You've got your M, your G1, your S, and your G2. And each of those phases is characterized by the structure of the chromosomes. So in G1, there's a gap between M and S, and that's your pre-DNA synthesis. So that's before your DNA has been created. Your S phase is your DNA synthesis. That's when your DNA starts to form or become replicated. And then you've got your G2, which is your post-DNA synthesis gap of the cell growth. So again, you've got 4 phases within interphase itself: M, G1, S, and G2. You do need to know the breakdown of each one, so make sure you pay attention to that. And then something important that probably no one can read on their screens because it's really hard to read my handwriting anyway, but just an important fact that radiation-induced chromosome damage can be analyzed in metaphase. So again, radiation-induced chromosome damage can be analyzed in or during metaphase. So that's when they're going to look at the chromosomes to see if any damage has occurred. And here's that wonky picture of the cell cycle. So as you can see, during mitosis, you have your major phases, which is prophase, metaphase, anaphase, telophase. And then during and in between all these phases is your interphase, and you can see your different phases of interphase, your M, your G1, your S, and your G2. And your S stands for synthesis, and that's really where the DNA gets replicated. Moving on to meiosis. During meiosis, this is your genetic cells that are reproducing. They begin with 23 pairs or 46 chromosomes, the same as somatic cells. But what happens is that instead of duplicating each of the cells during meiosis, the genetic makeup must be reduced by half so it can marry with another genetic cell. So that's how we're making babies. We're getting the cells together so that it can produce an embryo. The process begins just like G2 and goes through mitosis into the 2 daughter cells. And then those 2 daughter cells divide. So that second division is not accompanied by an S phase. So during that second division, you're not getting the replication of DNA. The DNA is literally unzipped and cut in half. Those granddaughter cells that form contain 23 chromosomes. During the second division, a process called crossing over occurs, where material is exchanged amongst the chromatids, which are just the little pieces on the chromosomes themselves, resulting in changes in genetic constitution and changes in inheritable traits. So again, when you are going under the process of meiosis, your genetic cells, they're not going to replicate fully like in mitosis and like your somatic cells. They end up dividing, and that second division is where no replication of DNA occurs, so there's no S phase. And then those granddaughter cells, they exchange information between the chromatids to see what gets inherited in what side and what gets inherited in the other. And then I wanted to point out the difference in radiosensitivity of the cells of the body. The most radiosensitive cell type would be your lymphocytes, and then secondary would be your spermatogonia, and then obviously your erythroblasts, which are your red blood, and then intestinal crypt cells, which we did talk about in class, but when your intestines break down, it's very hard for those cells to replenish. And then you've got your intermediates, and you've got your low, which would be your muscles and your nerve cells. These guys are not very radiosensitive, so when we start having enough radiation to affect the nerves, then you're pretty much looking at radiation death. But this one is super important to know. This is the most radiosensitive, and this is the second radiosensitive. And that's it for chapter 29. So moving on to chapter 30, fundamental principles of radiobiology. The law of Bergoni and Tribandot. Super important. You do need to know this. I believe it's a chart in your book, but we'll just read it again so you know. Again, the two men are Bergoni and Tribando, and the law states that stem cells are radiosensitive while mature cells are radioresistant. Again, stem cells are radiosensitive and mature cells are radioresistant. So new cells are more sensitive to radiation than older cells. Younger tissues and organs are radiosensitive, and that still goes back to that stem cell. Tissues with high metabolic activity are radiosensitive, so tissues that are constantly reproducing, those are more sensitive to radiation. And then high proliferation rate for cells and high growth rate for tissues result in increased radiosensitivity. So basically anything that's constantly reproducing or growing, like children were growing, they're going to be more radiosensitive than more mature or slower growing or slower metabolizing cells within the body. Some physical factors that affect radiosensitivity, the linear energy transfer, which is your LET, your relative biologic effectiveness, or your RBE, and the protraction and fractionation. And remember in class I talked about how this is usually in rad-onc, and this is how they deliver the doses to the patients. Protraction means that you're going to get a continuous dose over a long period of time, and it kind of looks like a protractor. And fractionation is generally one single dose broken up into equal parts, and equal parts are delivered with 24 hours in between, so the body can start to recover a little bit in between each dose. Again, here's my notes, difficult to read. I will go over them again. The responsive tissue is determined by the amount of energy deposited per unit mass, and that's your LET. So again, your LET is the how your energy gets transferred into your tissue. When we talk about tissue response, it's really determined by how much of the radiation is affecting or being absorbed by the tissues, and that's your RADS, your radiation absorbed dose. So if you have a higher linear energy transfer or a higher LET, as we talk about it, there's more energy getting pushed into the soft tissue. So again, the definition for LET is the measurement of the rate at which energy is transferred from ionizing radiation to soft tissue. So how much of that beam that patient is actually absorbing as we're taking the exposure. Another way of expressing radiation quality is through LET, and that's your KBP, your penetrability. So if it's a higher penetrating beam, it's going to be actually a lower LET, because it's not going to be, the energy isn't going to transfer as much into the soft tissue. It's going to penetrate through the tissue. LET is expressed in keV, or kiloelectron volts, of energy transferred per micrometer. Big number that you have to remember is the LET for X-ray. So the LET for X-ray is 3 kiloelectron volts per micrometer. And I will repeat that. The LET for X-ray is 3 kiloelectron volts per micrometer. You absolutely need to know that. That's a penguin in your book. You need to remember. And I am starting to lose my voice. I'm sorry. Okay. Now, moving on. As your LET increases, you're also increasing your biologic damage. So the more energy that's being transferred into the soft tissue of the individual you're irradiating, the more likelihood of biologic damage to occur, and also the probability of interacting with your target molecule, which is your DNA, gets increased. So high LET equals high biologic damage equals high probability of interacting with our target molecules, which is our DNA. Moving forward, we're going to talk about the relative biologic effectiveness, your RBE, which is the effect on biologic tissues from radiation. You are going to need to know the formula. RBE equals the dose of standard radiation needed to produce an effect divided by the dose of the dose of test radiation necessary to produce the same effect. This is in your book. Make sure you take a peek at it. That's the formula for RBE. And then standard radiation, the orthovoltage range, which I think I talked to you about when we were talking about how doctors used to treat skin diseases. They used orthovoltage, but in X-ray, the orthovoltage range is 200 kV to 250 kV. The diagnostics, can't talk anymore. Diagnostic X-ray has an RBE of 1, so that's also important to know. So along with what relative biologic effectiveness is, which is the effect on biologic tissues from radiation, you also need to know that with diagnostic X-ray, the RBE is 1. So as X-rays with LET becomes greater than 1, your relative biologic effect gets higher. X-rays with a LET less than 1, your relative biologic effect gets lower. What I'm saying when I write this is that as your LET increases, your biologic effect is going to increase. As your LET decreases, you're not getting that absorption into the tissue that you're irradiating, so you're not going to have the same type of biologic effect. So your biologic effect is actually going to reduce. Protraction and fractionation, I already talked about. It's basically when the dose is broken up and delivered into a longer period of time. The protracted is a continuous low dose delivery, and your fractionated is the same rate given in equal fractions, separated by that 24-hour period. And again, that is most common in radiation oncology. I do have a little example here for you. You will not have to do any math equations on the test, so you really don't have to worry about that. I'm sure everybody is having a big sigh of relief, but you just need to know what the formulas look like. You don't need to plug anything in for this test. I'm not promising anything for the midterm or the final, but for this test, you don't have to do it. There are several biological factors that affect radiosensitivity. They are the oxygen effect, a person's age, the recovery, chemical agents, and then that theory about hormesis, which I've said a million times, but that's the theory that a little bit of radiation can actually be good for you. And I'll talk to you a little bit more about that in a second. When we refer to age, humans are obviously most sensitive before birth. Then their sensitivity decreases until maturity, which they are most radio resistant. So as we become mature adults, our radio sensitivity declines. Then when we get a little bit older again and get into our elderly years, we actually become more radio sensitive. So we begin radio sensitive, then we become radio resistant, and then we become radio sensitive again. During recovery, human cells can recover from radiation damage if the radiation dose is not enough to kill the cell before its next division. So if the radiation doesn't kill the cell before it divides, that division would be interphase death. So if it dies during that division, then that's interphase death. If you don't encounter this, then given time, the cell will recover from sublethal radiation damage. So as long as the human cell or our patient isn't getting radiated while the cells, or the cells of the patient, I should say, are not getting radiated while they're going through the process of interphase, then they have the chance to recover. But if they are in the process of interphase and they get irradiated, then they're going to undergo what's called interphase death. And then you do absolutely need to know, very important, what encompasses recovery. And the two things that encompass recovery are intracellular repair and repopulation. And I'll say that again, there's two things that encompass recovery, and that's intracellular repair and repopulation. Some of the cells can repair better than others, and that all depends on age, maturity, how radio resistant they are. Other cells, once they're irradiated, can atrophy, which means they'll shrink and then die. I know I talked to you guys about the chemical agents, and there are some that make you more radiosensitive. There are some that can be radioprotective. The only issue and the biggest thing that you need to get from this slide is that doses for the radioprotectors need to be administered at such a high dose that it's actually lethal. So really, the radioprotective agents don't help us because they end up being more dangerous than the radiation themselves or itself. And again, here's this process of hormesis. A little bit of radiation is good for you. It can stimulate hormonal and immune responses, really important. So that's why they think that hormesis is good for you. Some people that live close to nuclear test sites or that live on high uranium deposits tend to have longer lifespans because the cells have learned to adapt and basically build up an immunity. So it did stimulate hormonal and immune response in that population. And just here's a little breakdown of the kinds of responses that cells can have. So after radiation exposure, if it's a high dose, you're going to have an early response, which becomes deterministic, which you can see right away. And then low dose, you might get a later response, and that's your stochastic responses. So that's the stuff like cancers that happen later in life. Dose-response relationships, which we talked about quite a bit in class. Deterministic has radiation-induced skin burns, which that was the fluoro that we mentioned. Fluoro, usually high-level fluoro, you can get skin burns. For radiation oncology, you can get skin burns. And then some of the stochastic things that happen later on in life would be your cancers, your leukemia, and your genetic effects. This is what the linear dose response looks like, and I had mentioned that it is directly proportional. So even at 0, you can still have a response, and it follows a straight line pattern. So as the dose increases, so does your line. So it is directly proportional, and they're nice and straight. Nonlinear simply means that they're not straight. So you can have different curvatures. You can have a sigmoid shape here. So it just depends on what specific illness or response we are talking about. Linear non-threshold dose-response relationships, that's going to be your cancer, your leukemia, and your genetic effects. So again, linear non-threshold dose-response relationships include cancer, leukemia, and genetic effects. And the reason why it's non-threshold is because no one wants to take accountability for any type of dose that's been given to a patient, so they consider it even at 0, there's still a response. That's your non-threshold. Your non-linear threshold, meaning it has to reach a certain dose before you can see the effect happen, would be that high dose fluoroscopy, and that's your skin effects. So that's your skin erythema from high dose fluoroscopy. Chapter 31, molecular radiobiology. So now we're just going to keep going with and building on what we've learned in 29 and 30. Once we've irradiated our DNA, which is our macromolecules, that's your direct hit, your target molecule, we're going to undergo some processes here. This is just a graphic of what those processes are. So A is showing a main chain scission, so where it's actually cutting the chain. And then you've got something called cross-linking, where the chain is cut, but then the stickiness factor, the chain starts to reattach in random spots. So that's how you're going to get your cross-linking. And then your point lesions are literally point lesions within the chain. So lesions within the chain. Here are my notes. These are a little bit easier to read. These are my old notes that I didn't want to put up, but I did because I love everyone and I want everyone to pass. It says chapter 34, but this is from a very old version of Bouchon, so please ignore that chapter. In vitro, you need to know, means outside of the body. In vivo is inside the body, and you are more radiosensitive in that state. And then a solution is a liquid with dissolved substances. For your test, you really don't need to worry about that. It's these two guys right here that you need to focus on, is the in vitro and the in vivo. This is a breakdown of the three major effects that I discussed in that picture in the previous slide, but I will review it again for you. Macromolecules irradiated in vitro undergo three major effects. The first one is that main chain scission, where it's a break in the backbone of the macromolecule. It reduces size and viscosity of a solution, and the measurements of viscosity equals the degree of the main chain scission. So those are the three main points for that, but that's that major break in the backbone of the macromolecule. Then you've got your cross-linking, where spur-like side structures with sticky ends attach to neighboring macromolecules and create weird segments. There is an increase in the viscosity of the solution. And then you've got your point lesions. Now, this is a disruption of a single chemical bond. It is not detectable, but can cause minor modifications of the macromolecule. So it's causing a malfunction in the cell. At low doses, point lesions can cause cell damage that can eventually lead to late effects, meaning your cancers and things like that. Very important at the bottom here, all three types are reversible through repair and recovery. I have to repeat that. All three types are reversible through repair and recovery. So all three of these can be reversed. Again, DNA is the most radiosensitive molecule in the body. Here's just a breakdown of the responses, where you've got main chain scission with only one side rail severed, a main chain scission with both side rails. And when they're talking about side rails, they're talking about the rails of the double helix of the DNA. Main chain scission and subsequent cross-linking. So you can actually get an initial main chain scission of the backbone of the DNA, and then that can lead into a cross-linking. Rung breakage causing a separation of the bases can occur. And then the big one down here, when there's a change in or a loss of a base, those four bases that we talked about with your DNA, the damage may not be reversible. So even though the previous section I said all of those can be reversed through repair and recovery, this one particular issue, when there's a change in or loss of a base, the damage may not be reversible. It's not impossible, but highly unlikely. And then some observed effects of DNA radiation. Obviously, you can undergo cell death, malignant disease, your cancers, and your genetic damage, which you can pass on to your offspring. Some major things that happen when the body is irradiated, we get those interactions, so we can have a direct or an indirect. And again, most of our reactions are going to be indirect. And the body will undergo a process called radiolysis of water. That's the breakdown of the water molecules within the body, and it eventually results in free radicals. And those free radicals can turn into something very poisonous in the body, can turn into hydrogen peroxide. So it's very important that we remember that the body undergoes radiolysis of water, and that water can go from H2O into hydrogen peroxide because of the radiolysis that occurs. But I just will read this section real quick. The body is composed of 80% water and less than 1% DNA. The breakdown of a water molecule equals free radicals because the X-rays ionize the molecule. So you're getting irradiated. The cells get hit. Most of our body is water, so it's most likely going to be a water cell that's going to get hit. That water cell now becomes ionized. So what happens is the water gets changed to hydrogen, oxygen, and another hydrogen because of that extra electron hanging out. So you've got an ion pair that can rejoin and stabilize the water molecule. You can not have that molecule rejoin the electron and can join another H2O molecule, ionizing it. So you can have it go back to normal, ionize another water molecule. Or what can happen is this unfortunate situation down here where you can get two free radicals and two ion pairs that form. And ultimately, you can get that hydrogen peroxide or hydrogen peroxyl, and that's poisonous to the body. And then this is just a definition of a free radical, which is an unchanged molecule that contains single unpaired electrons in the outer shells. They are highly reactive, and their lifetime is usually less than 1 millisecond. So that's the breakdown of water in the body. This is usually how our indirect hits occur. And then we move on. So the principal damaging product from radiolysis is that hydrogen peroxyl that forms. So when the free radical joins a similar molecule, you end up with this, instead of H2O, you get H and O2, and it ends up being that hydrogen peroxyl, which is no good. And this is just giving another explanation of your direct and indirect effects. Again, if an initial ionizing event happens on a target molecule, which is your DNA, it's considered a direct effect. If the, my dog is snoring really loud. If the ionizing event occurs on a non-critical molecule like water, the energy transfers and it creates an indirect effect, and that indirect effect results in some free radicals. Most of radiation in humans, or most of the effects of radiation in humans, is an indirect reaction. So you can still have direct and indirect, but with humans, most often it is an indirect effect that's going to occur. So again, you can have both direct and indirect effects, but the primary in humans is that indirect because of our water molecules. Chapter 32, Cellular Radiobiology. I don't know if I'm going to make it through this video. I'm dying. Okay. This is your single and your multi-target hit models. That's super confusing in your book, but we kind of broke it down nicely. What you just need to know is that there are two models of the target theory, and that your single target, single hit applies to very basic single cell organisms like viruses and bacteria. Your multi-target, single hit applies to human cells. Because the cells are more complex, it becomes a multi-target. Again, there's two models. One is the single target, single hit, and the other is the multi-target single hit. The single target single hit applies to single cell organisms like viruses and bacteria, and the multi-target single hit applies to human cells. And here is the target theory broken down. For a cell to die after radiation exposure, its target molecule must be inactivated. I will say that again. I will put my little pointer on it. For a cell to die after radiation exposure, its target molecule must be inactivated. And that target molecule is your DNA. So the DNA has to be inactive in order for that cell to die. Interactions between radiation and cellular components is random. Therefore, target interactions are random. So you're not going to be able to predict if your DNA is going to get hit or not. It's just a random event. Again, when radiation interacts with your target molecule, which is your DNA, that's what I've been referring to as a hit. A hit can occur both directly and indirectly. but we have no way of distinguishing between the two. So we don't know if DNA got hit as a direct hit or as an indirect hit through those water molecules. There's just no way to determine that because we cannot do human trials. Indirect hits equal larger target sizes because of the free radicals. You're getting more of them. It's more easy. That's horrible English. It's easier for that interaction to occur. And then a couple little fun facts down here. With low LET radiation and no oxygen, you have a very low probability of a target hit. Again, if you have low energy transfer and it's not an oxygenated environment, the probability of you hitting a target molecule, which is your DNA, is going to be pretty low. When you have oxygen present, your probability of a target hit will increase because of that oxygenation enhancement ratio. With high LET radiation, it doesn't really matter if you add oxygen or not. It's not going to do anything because if something's already high LET, it's already got a high energy transfer rate. You don't need oxygen to boost it. It's not going to do anything. But with a high LET radiation, you're going to already have a high probability of a direct hit because there's more energy transfer occurring to that soft tissue. So low LET, no oxygen, low probability. With oxygen, your probability increases. When you have a high LET, it doesn't matter if you add oxygen, you're going to have a high probability anyway. Very important to remember that your lethal effects of radiation are determined by cell survival, not cell death. Again, your lethal effects of radiation are determined by cell survival, not cell death. And the two things next that you do need to know is your mean lethal dose, which is your DO, and your threshold dose, which is your DQ. So your DO is your mean lethal dose, and a large DO indicates radio-resistant cells. So if you need more radiation to kill or harm or damage a cell, then that cell has a high or large mean lethal dose. A small mean lethal dose means that the cells were pretty radiosensitive. So these would be like your lymphocytes, and your large DO cells would be like your nerve or your muscle cells. With the threshold dose, it's kind of the same thing. A large threshold dose indicates that the cell can recover readily from sublethal radiation damage. A low threshold dose, however, means that the cell was pretty radiosensitive and cannot recover as readily to radiation damage as some of the other cells. Here are two formulas that you need to know from this chapter, and that's your relative biologic effectiveness and your oxygen enhancement ratio. This is another discrepancy. This shouldn't be here. It should be OER. Hold on. I gotta cross that out. It's gonna drive me nuts. Gonna drive me bonkers. Hold on 1 second. I have to yell at Bouchon now because I'm mad at it. Sorry guys, you can pause the video if you want. In the book it's right. See, that just annoys me. Ugh. Okay. Let me fix this because otherwise it's going to make me crazy. It's going to make you crazy. Nobody's going to be happy. All right, so this got to go. This, get rid of this. This should be O-E, terrible handwriting with a mouse, R. There we go. Okay, this is on page 505 in your book if you want to just double check that everything matches up. It looks like now that I've made that correction, everything matches well. But these are the two formulas that you would need to know. Again, I'm not going to make you do any math with them, but you just need to know the formula itself. Give you a few minutes. And I want my little pointer back. So I will get that. Again, this is on page 505 in your book. Please just double check that this is correct. I'm a little tired, as you can hear me rambling a little bit, but I just want to make sure that everything matches up. Okay. Chapter 33, this is your deterministic. These are the effects that happen shortly after some type of irradiation. And we just went over this, so hopefully it's still fresh in your memories. Acute radiation lethality. So with diagnostic X-ray beams, they are neither intense nor large enough to cause death. So you're not going to get that radiation death with X-ray. It could be with something else like nuclear accident, some type of miscalculation with rad therapy, some type of miscalculation with nuclear medicine. You're really not going to see it in diagnostic X-ray. Diagnostic X-rays always result in partial body exposure, which is less harm than whole body exposure. So we're always going to collimate down to a specific body part. We're not just opening up the cones and able to hit every portion of the body. It follows a nonlinear threshold dose response. So acute radiation lethality follows a nonlinear threshold dose response. So it has to hit a certain dose in order for it to occur, but everybody's going to respond a little bit differently. That's why it's nonlinear. As your dose increases, the severity of the response is going to increase, which makes sense because the more radiation you get, the more severe your reaction is going to be. Death can occur within days or weeks of high-level radiation exposure, which we will talk about in just a few seconds. There are those 3 stages that you had to discuss in your objectives, and we also discussed in class, but that's your prodromal, your latent, and your manifest. During your prodromal, it usually happens within minutes, so immediately following irradiation to hours after the exposure. It can last for hours to days, and it's mostly characterized by nausea, vomiting, diarrhea, and leukopenia, which is your leukocyte count is down. Your latent period is that period just following the prodromal where you feel better. That can last hours to weeks depending on your level of exposure. And then your manifest illness is when everything comes back full force and you are most likely going to undergo some type of radiation death. The 3 syndromes associated with acute radiation is the hematologic, the gastrointestinal, and the central nervous system. With hematologic syndrome, that's those doses, which you do have to know. These doses are between 2 and 10 grays or 200 to 1,000 rad. So you need to know both, so make sure you write it down, pay attention to it. Hematologic deals with your blood. So it's going to be a reduction in your white blood cells, your red blood cells, and your platelets. The prodromal symptoms with the hematologic syndrome are pretty mild. They will appear within hours and can last for a few days. They're not as severe as some of the other illnesses that we will discuss, but you still don't feel well. The latent period usually is approximately 4 weeks of feeling good. You feel like, maybe I had a little virus and now I'm feeling better. During that time, though, your cells are still declining. So you're still undergoing the syndrome, but you're just not feeling it. And then once the manifest illness occurs, it can appear within hours and last for several days. You get that nausea, vomiting, diarrhea. You basically feel like you have a virus of some sort. With hematologic syndrome, you can recover. There is possibility to recover from this one. So it can begin within 2 to 4 weeks, but it can take as long as 6 months. So depending on how severe it was, like the closer to the 10 grays that you get, will determine how long your recovery will take. If the radiation is too severe, you're going to just end up getting so sick. You're going to begin to hemorrhage because all your cells are breaking down. You're not going to be able to stay hydrated, and your electrolyte balance is just going to go haywire, and you are going to die. So depending on how severe that radiation dose was during hematologic syndrome, you could either recover or you will end up passing away. Very morbid, this section. With gastrointestinal syndrome, these doses are 10 to 50 grays or 1,000 to 5,000 rad. You're going to get that vomiting and diarrhea during the prodromal period. It will last a few hours. And then you're going to go through that latent period of feeling better. And then all of a sudden, the manifest illness is going to hit you, and it's going to be 10 times as worse as the symptoms from your prodromal period. You're going to end up going through stages of diarrhea where you end up with the bloody stools because your cells that line your intestines are just going to completely break down, liquefy, and just pass through. So that liquefaction of the cells and everything breaking down is just going to end up being a bloody mess, which is awesome to think about at, 12, 1 o'clock in the morning. I don't even know what time it is. Recovery. So there's nothing that really can stop the degradation of the cells in the intestine. You are most likely going to die from this type of an exposure, and death can usually occur within 4 to 10 days of exposure with your GI syndrome. Make sure you remember that, 4 to 10 days after exposure. And with exposures high enough to cause GI syndrome, it can impact your hematologic system. Your cells may never recover, and you're going to end up basically dying from infection because you're not going to be able to fight anything off. Central nervous system syndrome. Now, if you remember, your nerve cells are the least radiosensitive in your body. So in order to have some type of reaction occur, you need a huge dose of radiation. So these are doses greater than 50 grays or 5,000 rad. The prodromal period is not going to be fun. You're going to feel severe nausea, vomiting within minutes, confusion. Your skin's going to feel like it's on fire. You're going to lose consciousness. Your latent period is only going to last for maybe 12 hours. And then it all starts over again and just gets worse. The patient ends up dying from a swelling on the brain from vasculitis and meningitis because the body just fills with fluid. All your organs shut down. Something we definitely don't want to experience in our lifetime because I can imagine it's pretty agonizing. This also is in your book. It's just a breakdown of the doses that need to hit, so those threshold doses before this type of effect can occur. And this is whole body versus small field versus local tissue versus whole body. So this is all broken down. This is a nice way to remember the doses that are needed. So pay attention to this chart. I think it is on... I'm looking. Hang on. I'll tell you in a second. Maybe. I might be lying. It's table 33-1, page 508 in your book. So yeah, you might want to know these. These are important. Also, I talked about your skin erythema dose, which is the reddening of the skin. That was what we used to originally formulate radiation protection practices. That SED 50 is 5 gray or 500 rad, and that's the dose required to affect 50% of those irradiated. So that's the dose required for 50% of the irradiated population to get reddening of the skin. That's your SED 50, 5 grays. Make sure you know it. Also very important, this lovely chart right here, and it is on page... it's coming. Maybe not. I could be lying. It is on page 513. It is table 33-4. Need to know these. So there is maybe 1 or 2 questions that have to deal with this. So make sure that you know the threshold dose and the onset times. But mainly the threshold dose is what you need to pay attention to. Effects on the gonads. So responses as low as 100 milligray or 10 rads have been observed. Critically important organs, male obviously is testes, female is ovaries, and the stem cells for those 2 organs are your oogonia and your spermatogonia. and they reproduce by or mature through a process called gametogenesis. What is different between males and females is that females are born with all the oogonia that they're going to ever have. We're not going to be able to reproduce them. And our oocytes are the most radiosensitive cells during germ cell development. So for females, oocytes, most radiosensitive. Some doses that you need to pay attention to. 10 rads will suppress menstruation. 2 grays, 200 rads, temporary infertility. 5 grays, 500 rads, permanent sterility. All important. The hemopoietic cells, this is your blood system. Broken down, you've got your lymphocytes, your granulocytes, thrombocytes, erythrocytes, neutrophils, I know was on a slide previously, and that's like another kind of neutral party, but it's a scavenger white blood cell. It kind of rushes to the scene when there's an infection in case you wanted to know more about them, but it's not really included on the test, but just in case you're looking at those slides. Lymphocytes, that's your most radiosensitive. That happens with your immune responses. And you've got your granulocytes, which are your scavenger cells to fight bacteria. Your neutrophils would be in this category as well. You've got your thrombocytes, which clot blood, prevent hemorrhage. Your erythrocytes, which are your red blood cells that give oxygen to the body. And then after exposure, the first cells to become affected are your lymphocytes. You undergo lymphopenia, which is lessening or reduction in those cells. And again, I cannot stress enough, lymphocytes and spermatogonia are the most radiosensitive cells in the body. Lymphocytes first, spermatogonia second. And then briefly, chromosome aberrations follow a non-threshold dose response because nobody wants to say how much dose exactly can cause them. They are very difficult to observe under 10 rads or 100 milligray. You can have a single hit chromatid deletion, which is breaking the chromatid into fragments called isochromatids. That can occur at very low doses, and it follows a linear, so it's proportional, non-threshold dose. Again, the single hit chromatid deletion follows a linear non-threshold dose response. Your multi-hit aberrations can make ring chromosomes, which look literally like rings. You can have dicentrics, which have 2 rings, so two of them stick together. Reciprocal translocations, where it's rearranging the genes, but you're not losing any genetic material. This type of reaction can occur at 1 gray or 100 rads or more. The difference between your single hit and your multi-hit. Single hit is linear, non-threshold. Multi-hit, non-linear, non-threshold. Because it's non-linear because these are your complex cells and we don't know how radio-resistant or radiosensitive each particular cell can be. And this requires the same chromosome to either be hit twice or neighboring chromosomes to be hit and then combined. So that's your single hit and your multi-hit. Chapter 34, and thank goodness we're almost done because I am losing my voice. I'm exhausted. So let me go through it. I'm probably going to go through it quickly. I apologize. With Chapter 34, you've got your risk estimates, and I did update this slide. So you've got your relative risk, which you need to know these two especially. Your relative risk is your observed cases divided by your expected cases. Your excess risk is your observed cases minus your expected cases. And again, please check this in your book. I'm going to actually double check it now while I'm talking to you. Yep, that is correct. So page 526 and 527 has those formulas available for you. And then I have this absolute risk listed. This isn't on your test. More these two here. And again, this is just breaking down your relative risk, which is your observed over your expected. And a relative risk of 1 indicates really no risk at all. Once you get to the 1.5, that's when you have a late response 50% higher than anyone who has not been radiated. And then the relative risk for radiation-induced late effects of particular importance in humans is in the range between 1 and 2. So really anything when we get irradiated, we're looking at the relative risk in the 1 to 2 range. And then I don't know if you remember, I had mentioned that the childhood leukemia is that 1.5 if they've been irradiated in utero. So that's a number you'll need to know. Oh, look, here it is, radiation-induced leukemia. You need to know that the latent period for radiation-induced leukemia is 4 to 7 years. The at-risk period is 20. It follows a linear, non-threshold dose response. And it really has no relevancy with RTs getting exposed to radiation. So the big one here is your latent period is 4 to 7 years. Here's some other cancers that are mentioned, perhaps some of them on your test. Thyroid cancer from thymus gland irradiation, bone cancer from your radium, because your radium behaves like calcium and goes straight to the bone. You've got your skin cancers, which follow a threshold dose response, so it needs a specific dose for it to occur. Your breast cancer follows a linear, non-threshold dose response. Lung cancer from uranium miners, and that thorotrast that we used to use, that contrast media, can cause liver and spleen cancer. Radiation and pregnancy. So, chronic low doses of radiation really doesn't impair fertility. The first trimester is always the most radiosensitive because that's when the major organogenesis occurs. During those first 2 weeks, however, that is that point where it's all or nothing. It's either going to be a spontaneous abortion or the baby is just going to continue developing naturally. The relative risk of childhood leukemia after irradiation in utero is that 1.5, like I mentioned earlier. And then radiation exposure in utero also slows the growth and development of the newborn. So these are all kind of important bullets or important points to remember for radiation and pregnancy. Genetic effects of radiation exposure follow a linear, non-threshold response. All mutations are harmful. Don't worry about this one. Exclusively naturally occurring mutations, not for your test. Don't worry about it. It is dependent on fractionation and protraction, so how the dose is delivered, whether it's immediate and a lot or delivered over a long period of time. Yay, females. We're less radiosensitive than males, so guys, I apologize. Most mutations are recessive, meaning that they won't get passed on to our offspring. Your doubling dose is the dose of radiation that produces twice the frequency of genetic effects as would have been observed without radiation. So that doubling dose can have the patient have twice the risk or effect of whatever would occur without radiation. So like a cancer, like leukemia, like a genetic effect, something like that. And these doubling doses were determined by studies on mice and fruit flies because we cannot study humans. So again, all our studies were done on mice and fruit flies, so we have to thank them. And another thing that's not on here, and I just forgot what I was going to say. That's awful, and I know you guys are probably dying right now. I can't remember what I was going to say. Let me keep going. Some things to remember. Radiation-induced cataracts follows a non-linear threshold effect or dose response. So again, radiation-induced cataracts follows a non-linear threshold response. It occurs on the posterior pole of the lenses. The threshold dose for cataract formation is 2 millisieverts of acute exposure to the eye. At worst, humans can expect a reduced lifespan of approximately 10 days per 10 milligrays of exposure. And guys, you better count your milligrays because you are far more radiosensitive than females. And then also something important, after all this horrible stuff that we talked about, radiation technology is actually a safe occupation. They monitor us really well, and we're not really in contact with the beam itself. It's our patients that are in contact with the beam. The only time that we're really getting exposed is if we're holding or if we're in some type of a fluoro procedure where we're getting that scatter. Once you get into the more advanced modalities, you're even sitting outside of the room in control rooms away from the apparatus. So it's just, you're really not getting that much exposure. And that's it for your test. Again, it's 100 questions. I'm sorry if I rambled. I'm really tired. I hope this microphone is better because I really don't want to repeat this if I don't have to. I just want to look through the test quickly. Give me a few moments so that I can see that I've covered everything, because there was something I wanted to tell you and I forgot what it was. I might have covered it already. Let me just make sure you got your minimum doses in your chart. Yeah, so the minimum lethal dose for humans is 2 grays. Let's see what else. The SED 50 was really what gave us our radiation protection, and those are based off of, I believe, stochastic guidelines. So please make sure you read that section really well. How we base radiation protection is generally off of our stochastic effects that occur. So like your cancers, your genetic effects, your leukemias, things like that. No, I think I covered pretty much everything. I'm just taking a peek, looking around. Looks like everything has been covered. Again, I apologize. I'm pretty tired doing one of them late night videos so that I make sure when you wake up you are nice and happy and you have your videos ready for you. Some of you I will be seeing for tutoring. Others, if you have any questions, please reach out to me and I will be glad to help you. So I hope this video is helpful. It is a long test, 100 questions, but it gives you a little bit of leeway in order to do well. And it all builds on top of itself. So from 29 to 34, all of the information is building on itself. And that's really it. I'm going to get out of this slideshow if it lets me. And I'm going to end the recording. Everybody, good luck and deep breaths. Don't panic. And I will see you on test day. Thanks.